Good afternoon, Gunther.
Can you hear us, Gunther?
Yes, I can hear you now. I've had endless trouble. Sorry about the breakdown in technology.
No worries. Thank you for joining us. Were you able to hear the last few minutes?
No, Krishna, I sat right from when you started the conference, right through your tea break, and everything worked well. And then during the tea break, I could hear you people having some hilarious fun talking to each other. And as you came back, I heard you speak, and then the video started. And as the video started, the whole thing just crashed on me.
Okay. Well, great. Thank you for being available. Let's see if we can go to the audience and any questions, comments. So while we wait, please, anyone who's interested in enjoying the conversation, make your way to the mic. Maybe I'll delve a bit more and ask Gunther specifically about the lessons learned. You were part of the experience with a private sector approach in Kenya. How did that experience inform, and what were the specific changes that you thought the model required to be successful in Rwanda?
Okay. Can you hear me well? Because you're breaking up very badly.
Sorry, we can hear you.
Okay, that's the most important thing. Now, Krishna, if I can get you right, is you want to know what the experience was. So the bottom line is that you have to have some funding flow into the system if you want to make it a business sustainable model. Because as we all know, in the developing world, at the BOP, there's a lot of informal work. There's not a lot of employment. And it means that people haven't got the money to go and spend on healthcare. So there's no doubt that you need some kind of either provider-driven subsidized health insurance or a government-sponsored health insurance. That's number one. And number two is you have to scale, and you've got to scale rapidly. And number three is you have to run it as a business. You can't put the franchisees in and not charge them anything. So it can't work as an NGO model. So I'd say those are the three issues. And obviously we've had a huge learning curve coming into Rwanda as well. There's a lot of, we now, fortunately, we're getting a lot of granular information, and we know where the franchisees aren't doing as well as they should, and we're starting to analyze the reasons why not to try and improve the model overall. So I don't know whether there are any other questions or anything else. I was hoping just to catch in, and have you discussed yet as Lila mentioned, the issues of what is required for a franchisee to join the network, and what kind of basic training we give them and what ongoing training we give them.
Yes, thank you, Gunther. Yes, Lila touched on the perspective of a franchisee and what that interaction looks like. So I think we have a question.
Okay.
Thank you so much. Actually, I'd like to follow up on his comment. I understand that you allow A2 nurses to be franchisees. In Rwanda, that is the lowest level of nursing education. It's a high school education. And all of those A2 nurses are being required to upgrade to a diploma. So I'm wondering what standards are you using? How do you know that these nurses are qualified to provide this kind of care? What's the vetting process? And do you have a plan for them to upgrade their education?
Maybe I'll start with the answer, and then Gunther can chime in if there's anything else to add. We do work with level A2 nurses, and that's actually part of our agreement with the government. Given the nurse shortages at the national level, as in many other places around the world, there was concern from the government that we would be drawing too many nurses away from the community health centers. So we work with the level A2 nurses. The recruitment process involves screening. As I mentioned, in theory, they already have the training that's needed to provide the services that the One Family Health clinics offer. And as I mentioned, that really is, it's the very lowest level of the health system, and so it's primary care and it's limited in scope. But we do, everyone conducts takes an exam to make sure that their capacity is actually up to speed with their level of training. And then there are 2 weeks of initial training to bring everyone up to speed, make sure the capacity is consistent and to orient them towards our standard operating procedures and protocols. So that's the starting point. And certainly, not everyone that applies is accepted and is at the right level. But they are all experienced. We're not working with anyone directly out of school. We don't, at this point, have a plan to provide additional certification training for our current franchisees. I think that we would welcome the opportunity to recruit a higher level of nurse in the future and provide a higher level of care at the One Family Health clinics. The Rwandan government, with the help of a lot of partners, are investing aggressively in education and increasing the workforce at that higher level. So that's where we are. It's not our first choice to be limited in terms of the level, the scope of care that we can offer at the clinics, but we do, with the initial training and then consistent monitoring, both through the electronic platform. We can do some monitoring of, is one nurse providing, is anything out of sync with what's happening across the rest of the networks? We can do sort of exception monitoring around, prescription of different drugs or even just diagnosis of something that's not showing up anywhere else. And then we also have direct management support through technical representatives. That's our sort of main strategy for managing. Each is responsible for an area of clinics. So, does that answer?
This is Akiko Maeda from the World Bank. Thank you very much for a very exciting project description. I just wanted to make one comment that I'd be very interested to see what are some of the policy and regulatory environment reforms and capacity buildings that may be required where we could complement and collaborate with you, because we also have different financial instruments that help support governments make those transformations. So that's something I wanted to discuss and propose. The second question I have is related to that. Is one of the biggest challenges and pushbacks we face when we support this kind of entrepreneurial approach is from many partners who are concerned that this could lead to for-profit expansion and is going to create more risks and the out-of-pocket payments, catastrophic payments. In countries that have more health insurance approach where it's easier to contract out, maybe easier to make a case. But are you finding this transition in bringing up the entrepreneurs and then ensuring some subsidy flows so that those communities will not be exposed to financial risks? I mean, how do you find this in managing, from your experience, that sequencing and ensuring that? Do you see that as a challenge? And in countries that don't have health insurance, more of a national service, government-run systems, I think this is going to, is it likely we'll meet more resistance from that? So I just wanted to hear from your perspective. Thank you very much.
Thank you. Maybe I'll answer your first question a little bit about some of the regulatory, partnership challenges, and then I might ask Gunther to step in and share a little bit more about some of our thinking about opportunities in countries that don't currently have a national health insurance system. So I think in taking Rwanda as an example, one of the challenges that I highlighted has been the health insurance reimbursement process. And I think the country was still learning about the implementation management of this fund. The introduction of, the multiplication of the number of sites that were submitting claims for reimbursement, I think also tested the system a little bit more. In some small, tiny part, perhaps due to the entry of One Family Health, the government of Rwanda had initiated an assessment process to look at the Community Health Insurance Fund, because we were not the only organization, we were not the only clinics that were also, district hospitals that are not getting reimbursed the way they need to be. But a huge assessment and big change has taken place, and as of July of this year, they're actually transitioning the management from the Ministry of Health over to the Ministry of Finance, and the administration of the fund will fall under the Rwandan Social Security Board. So I think this is the kind of sort of, you know, I don't believe that the World Bank team in Rwanda has been involved to date with that, but I've had some conversations with some of your other colleagues about, you know, whether there's a need for additional technical support there around that transition. And so I think certainly in other places, that's probably still an area for support to the government about how to administer a fund like that effectively. The other sort of regulatory challenge that we still face in some places, I mentioned that we're in some stage of exploring expansion into Zambia. We conducted a country assessment and sort of put together our economic modeling, had identified some financing partners in Zambia, but although nurses provide a lot of services in Zambia, they are technically not authorized to provide all of them. And so introducing a model that would rely on that service provision just revealed that there's a disconnect between the policy around task shifting and, you know, the reality on the ground, which of course is not the only country where we see that too. So even though task shifting is happening more and more, there are some barriers to our model and to others like it. And then I think, you know, one of your other questions, I'm not sure I captured all of it, but I think one of the questions you're asking is what are the opportunities in places that don't currently have a national insurance fund? And Gunther, maybe you can chime in here to talk a little bit about what was envisioned in Zambia, where there is not yet a national insurance fund. Go right ahead.
Lana, I think the best thing for me to do is I can hear you fairly well, but not too good, and I cannot hear any of the other questions. So I think, you know, basically it's frustrating sitting here and I can't hear what's going on. In terms of the Zambian, I gather you want to know how things are progressing in Zambia. Is that correct?
Well, Gunther, maybe I'll give an initial description of the work around initiating a provider-driven health insurance scheme, and you can...
basically, because Zambia has not got any national health insurance. The only two countries in Africa that have a nascent health insurance is Ghana and Rwanda. Those are the only two. Now, in Zambia, the same size population, but a much bigger country than Rwanda, we had the funders. Everything was ready for us to run, and the funders were going to, for the first 3 years, contribute 50% to the cost of the treatment or services provided to the people. And over a 3-year period, we were going to collect all the data on our electronic platform and then get a health actuary to run it through and then develop, based on that, provider-driven, subsidized micro-health insurance. Now, the Zambian government, who we were working closely with, we did our country assessment study through the University of Zambia economics department, who the government have used them extensively too. And with them, we started a dialogue to see how we could develop that, because the Zambian government thought if we could crack that, then obviously it'll be a great opportunity to expand it into the rest of the population. So we had some of the funding lined up. It's also not a cheap exercise to do, but unless we can, in actual fact, get into the market and run our clinics for 2 to 3 years and gather all that information and do health actuarial evaluations going through, it remains a theoretical exercise. But we believe that based on what the Zambian market threw up in terms of drug prices, etc., that our model would be able to fly, providing we could have this subsidized health insurance and involved in it either through data-driven or partly government-driven.
Great, thank you. And I'll add, I think one of the points you'd made was this potential risk to create for-profit entities and associated risks. And I think in reality it exists today, right? So, and in reality, we manage this network of 55 innovators. The majority of them are for-profit. They're all private sector, and in fact, that's where a lot of innovation's coming from. So if we presuppose that there's nothing good from a for-profit private enterprise, I think we're leaving a lot of innovation behind. So I think it's actually going to take an evolution in thinking of how we actually harness that mechanism, right? It's just a corporate structure So how do we harness the work that's happening in the private sector, whether it's for-profit or nonprofit, and create the right mechanisms for partnership and integration into public systems in much of the world to actually try to scale the impact it's having? I think
Yeah, 100%. And I think the important thing one has to remember here too is when you're working at entry-level healthcare, primary healthcare services, and you want to keep your costs as low as possible, and then obviously your return on investment is going to be affected. We can take our model and put it in a country, a developing world country, and cater for white and blue-collar people in employment, and it'll work. But it is you want to work at entry level, because that is where the huge issue is. In my experience, traveling around the developing world, is that last mile, getting it right to where the services and treatment is needed, and that's where it's required. I mean, if we look at talking about costing, the specific clinic that we showed you there, the 50th, run by a lady by the name of Jean, she started basically between March and December. She saw, I think, about 3,500 patients. So it's about 350 a month, and it's constantly growing. And the average cost per patient from the time she started until the end of December worked out at $1.86 per patient, which is a pretty good deal. And even with that, she, as a franchisee, have been able to start nibbling and paying back a loan, and it is there. It can work, but it's just to balance it.
Great, thank you. Are we out of time, or can we take one? We're out of time. Okay, all right.
Thank you, Gunther.
You can take a couple minutes of my time.
The reason I'm up here is so that Gunther can hear us. Apparently, he can't hear from that microphone. I had just a quick question about, Lila, you said that to achieve sustainability, you needed about 250 clinics, and I wondered if you could expand a bit on the factors that contribute to sustainability, and do the franchisees, beyond the initial investment of the $500, do they have to share their profits or make an annual payment or something like that?
Sure.
Yeah. So what happens is they put on the $500, and obviously you know what we give them for that. They give the drugs, we give them training, we give them basic management training, finance training, obviously on Rwanda disease protocols, and we fit out the clinics. And you're looking at roughly about now $6,400 per clinic. They have a 5-year loan that they've got to pay back. And this is the only thing that we subsidize, because the interest rate in Africa is on average 18 to 19%. So they get a 9% interest loan, which they have to pay back over 5 years. There's a monthly capital, a repayment, obviously interest payment. And they chip away, and within 5 years, they clear the debts. But we find a franchisee, providing they get enough feet through the clinic, they see the patient level, that they, within 12 months, break even and start moving into a profit situation. Obviously, you deduct the clinic costs to run the clinic. They've got support staff, which is a very important factor. We created, I think, about 318 new jobs in the private sector in Rwanda in the rural areas of the country. So after all their costs are taken in consideration and the loan repayment, they started to show, they can make money on it. So basically that's how the model works. So to get sustainability at franchisee level happens fairly quickly. But for franchisor, because our income as a franchisor, we basically charge a 6% royalty and a 2% marketing fee. We've got a small markup on the drugs, but that markup, in actual fact, that's our distribution cost to get it there. So we don't make anything on that. So our income is basically 8% of gross sales per micro clinic. So obviously, as they scale the number of clinics, and we scale the clinics and they see more patients, that is our 8% income. And when we first started the modeling between 250 and 300 clinics, we were hoping that the franchisor will be moving to a point of breaking even, which means our costs are also covered in country. So that is the main idea, and is to get it to that level, because if you can get it to that level, then obviously you've got a totally sustainable system. But the most important thing is to get sustainability at the nurses level. And it's amazing to see the amount of effort and time these nurses put into their own facilities. They work sometimes from 8 in the morning till 8 at night. They work 6 days a week. If the community wants them to be open 7 days a week, they hire another nurse to come in. So they've got skin in the game. And once there's somebody who's got skin in the game, they make sure that they provide that service that the community wants from them.
Thank you. And I think we're over time, so please join me in thanking Gunther and Lila for joining us.
Thank you. And I commented to several of you at the break that if we had a couple days, we wouldn't exhaust this topic. But we're clearly going to go away with a lot to think about and a lot to continue to work on. And that really does move us to the next topic, the way forward. And Beth Bafford and Ambassador John Simon will be starting us on that, and then we will conclude with about 25 minutes, a little bit of summary and then discussion.